everyone. Thank you so much for joining us today as we explore what's new in spinal muscular atrophy. And so today we have two presenters. We have Dr. Julie A. Parsons from the University of Colorado, and we have Dr. Sarah Wright from Children's National Hospital.
And thank you for the introduction. Today in this webinar, we are going to review understanding pathophysiology of SMA, diagnosing SMA, some treatment approaches and FDA-approved therapies, look at some of the emerging SMA phenotypes that are now present in this era of disease-modifying treatments. We'll look at some new therapeutic approaches, trials and studies, and then give you some key resources to facilitate SMA care. Next slide. So first, let's look at the disease state so that we understand spinal muscular atrophy. Next slide. Spinal muscular atrophy is a disorder of the anterior horn cells, the motor nerves. It's a motor neuronopathy. And these cell bodies live in the ventral aspect of the spinal cord. These are the same cells that are involved with diseases such as poliomyelitis or ALS. On chromosome number 5, we have the genes for SMN1 and SMN2, survival motor neuron 1 and 2. In patients who have SMA, either they are missing or there is a malfunctioning SMN1 gene. And that's unfortunate because the SMN1 gene is actually responsible for producing about 90% of the SMN transcript. So without that gene, we have a backup gene called SMN2, and that gene produces only about 10 to 15% of functional protein. Next slide. So we think about SMN2 as a modifying gene in SMA. So in general, disease phenotype with humans can correlate with the SMN2 copy number. So for instance, the most severe phenotypes tend to appear when we have lower copy numbers of SMN1, and in patients or people who have 5 copies of SMN2 as a backup gene, they may be completely clinically unaffected. Next slide. Unfortunately, though, this is not absolutely clear-cut, and it is really important to remember that although there's a nice association between SMN2 copy numbers and disease phenotype, it's not absolute. So for instance, in the most severe phenotype, the SMA type 1s or the non-sitters, in general, those patients will have 2 copies of SMN2. In ambulatory patients with spinal muscular atrophy, in general, they will have 3 copies or 4 copies. But if you look, you can see that actually some ambulatory patients still only have 2 copies of SMN2. So the correlation really isn't completely exact, and it's important to remember that as we're thinking about treatments for patients with SMA. Next slide. Spinal muscular atrophy is inherited as an autosomal recessive disorder. And this is important to let patients know about as well, because sometimes they think, oh, if I have a 1 in 4 chance of having a baby with SMA, if I have a baby with SMA, the rest of my children will be fine. So it's important to remember and to educate patients about the fact that this autosomal recessive 25% occurrence happens with each pregnancy. Next slide. And Dr. Wright's going to talk a little bit about the diagnosis of spinal muscular atrophy.
Thank you, Dr. Parsons. Next slide. So I think it's important for us to think about the diagnosis of spinal muscular atrophy, both from the historical perspective and how that has changed in the advent of newborn screening, and what are some of the things that we really still need to keep in mind. So as Dr. Parsons had highlighted, there is a variability based on oftentimes the backup SMN2 gene. As we can see here, that copy number can sometimes correlate a little bit with your overall severity, but it's not exact. And so historically, prior to the generation of, newborn screening and genetic testing that was more readily available, spinal muscular atrophy was diagnosed based on the age at presentation, and then the overall gross motor milestone achieved. So we can see here that those individuals really with no copies of SMN2 or one copy of SMN2 may have actually death in utero or immediately following birth. And those babies who have type 1 were those who never sat, and they had significant proximal weakness. And then if you go up to type 2 and type 3, those are children who could necessarily sit independently, but type 2 may never walk. And type 3 really would lose ambulation either at an early age in life, so less than 3 years of age if you were type 3A, or would walk independently and lose ambulation later. Now, as we talk about therapies, it is important to remember, even for our adult colleagues, that there are some patients who have 4 or more copies of SMN2, and they may actually never present until adulthood. So it is important to remember that this is mostly a childhood onset disease, but there are some patients who will present with proximal muscle weakness in adulthood who, of course, never would have been caught on newborn screening. And so it's important for us to keep on our differential. Next slide. And so these photos show quite nicely more of the severe phenotypes that we can see with spinal muscular atrophy. And so, as initially described by Wernig Hoffman, the floppy infant in SMA type 1, those are the photos here on the left. And of course, we can see in the middle some, phenotypic features that are consistent with low muscle tone or hypotonia, including frog leg positioning, the head lag with pull to sit that can be very pronounced in a newborn and persist past 2 months, particularly in those patients with type 2 SMA, as well as, and we can see in the far left, some of the features that are, related to really decreased movement in utero, so the bell-shaped chest. And if you were to look closely, you would see tongue fasciculations as well, reflective of a motor neuron disease. Type 2 SMA, as we can see here on the right, this is a sitter but may never walk. And similar phenotype in the fact that you can see low muscle tone, very slight stature. And if you look at patients with type 2, type 3 SMA, they may have more of a predominant neurogenic tremor with reaching the arms out. They have a little bit of shaking. And they also may have actually in type 3 or type 4, actually more prominent calves that has been described. So these were all very important for the detection of SMA prior to the advent of newborn screening. And we still see these phenotypic features, particularly for those children who are more severely affected. Next slide. And so this is a very complex testing algorithm, and we won't get it into too depths, but we want to really kind of point this out because this is important to how we understand newborn screening. And so really, when we talk about the patients who have SMA, over 95%, approximately 95% of them will actually have a full homozygous deletion on SMN1. And this is what is detected on newborn screening testing programs. If that is detected, then we have a diagnosis of chromosome 5q, spinal muscular atrophy, and then we go on to determine the copy number. However, if there's only, essentially a mutation on one side of the allele or compound heterozygote, you may not detect that on the homozygous deletion. So you have to actually go on, if you have a high suspicion, to actually look at the gene count for SMN1, and then to really sequence the gene if you still have a high suspicion that spinal muscular atrophy persists. Next slide. And so these are really not used, but other diagnostic testing that you may see and may sometimes confuse the picture is that actually in some individuals, the creatinine kinase may actually be 2 to 4 times fold elevated. That is a relation to the motor neuron obviously not giving a message to the muscle and then having some muscle breakdown. And then, of course, if you were to conduct a regular electromyography and nerve conduction studies, you would see normal sensory responses, but then decreased compound motor action potential amplitudes, as well as neurogenic changes on your needle study. The EMG still has a role for us in sometimes predicting for those children who have, 3 copies of SMN2, maybe how severe they are at presentation and can help sometimes, particularly with clinical trials for understanding response to therapy. However, in the advent of newborn screening, these diagnostic modalities are rarely used. Next slide. And so newborn screening, this was really, a very new phenomenon when we talk about the course of SMA and the natural history of SMA. It really wasn't until 2018 that it was fully recommended and added to the RUSP. And so since that time, there has been a lot of advocacy on patient and family groups, as well as nonprofit organizations such as Cure SMA, to push newborn screening. And now, as of January of 2024, all 50 states and Washington, D.C. have genetic testing for spinal muscular atrophy included on the newborn screen. And this is really important to know what state you are in, and also when they added it to their particular newborn screening, because again, there may be some children who are missed if they were born prior to the event of newborn screening and have milder phenotypes of SMA. Next slide. And so, as I touched on before, the limitations of newborn screening is that we are really detecting those who have homozygous deletions of the SMN1 gene. So it can miss about 2 to 5% of cases. And then rarely there have been the risk of false positives that have been reported. This is oftentimes depending on the state's method for which they detect the homozygous deletion, the PCR. And this can sometimes co-occur with patients who are positive for SCID, which is an immunodeficiency, based on their state's methodology. However, false negatives reassuringly have been very rarely reported. And again, like I mentioned, this was implemented on a rolling basis, meaning that there's still older children who may present with symptomatic disease. Next slide. And so this has really changed the overall approach to care, where we are actually now treating most children pre-symptomatically or really soon after birth. And so there were some recommendations in recent articles, this one here talking about the newborn screening by Dr. Zeidman, that came out with really a kind of path forward and a pipeline for how we can detect patients on newborn screen, get them into a specialist, and then get them started on treatment. It's really dependent on the geographic location for each patient, where they're born, if they're referred to their primary care doctor, a specialist, or both, but it's most commonly that they'll be referred to a specialist center that specializes in spinal muscular atrophy. And some states actually will report out copy number of SMN2 and do even genetic confirmatory testing from a CLIA-approved lab. However, for most states, after that newborn screening is positive, that will be done by the actual center. And so here you can see kind of a goal timeline with really trying to get to therapeutic planning and treatment as soon as 2 weeks post-birth. When you look at kind of overall how states and specialists are seeing this, I think that what we can see is that many patients are being seen within the first week after being identified on newborn screening by specialists. But sometimes, as pointed out in this study, there can be delays in starting treatment, either for clinical reasons secondary to potentially maternal transfer of antibodies for our gene therapy, or insurance issues. And so these are all things that we need to target to try to get that treatment window down. Next slide.
And we do have, fortunately, treatments for SMA that we're going to talk about a little bit now. But let's look at a case first. So this is a 13-year-old teenager with spinal muscular atrophy who's brought in by their parents to discuss treatment. The teen has been reluctant to be treated, but recently stopped walking and is now seated full-time. The family is concerned about potential continued loss of function, especially in the arms and hands. And the teen will be starting high school in the next couple of months. So what should we think about in terms of treating this teenager with SMA? And what are some of the things that we really need to consider while we're making this choice or this decision in conjunction with the patient and their family? Dr. Wright, do you have any thoughts or anything that you would highlight in terms of what you think about in this situation?
Yes, this is a hard case, and I've experienced this as well, similar to probably most clinicians. And I would say that one of the things that's most important is having the patient, especially of an adolescent, involved in their care and being willing to move forward with treatment. But some of the things to think about from the medical aspect and advising them is the fact that we do know motor neurons are continuously lost. And the best way that we can have to preserve function is implementing a treatment that targets, SMN2, which is what we have approved at this point for a child this age, to try to augment some of that loss of function.
I would agree. And I think that other things that we think about, particularly with a young teen, is what are their expectations? What are the family's expectations? If the teenager has just been seated, do they expect to get up and walk when they're treated? And is that realistic? What kind of medical situations are we thinking about with this patient? So I'm assuming this patient is probably able to be an oral feeder. Do they have a scoliosis, or do they have any difficulty with orthopedic issues that might make it difficult to administer some of the treatments? How compliant would this 13-year-old be? Sometimes 13-year-olds are more compliant than 15 and 16-year-olds are in terms of treatment. So if there were a daily medication, would that be something that the patient would actually take? And then if this patient is female, we would wonder about the possibility of teratogenicity of any of the treatments that we give. If this is a male patient, we would wonder a little bit about, again, fertility and spermatogenesis for this patient. So all of these are things that come into our thought process when we begin to talk to patients and families about the treatments that we have available. So what FDA-approved treatments do we have at this point? Next slide. Before I do talk about those treatments, I think it's really important to also highlight and reinforce that the consensus care guidelines that now are a little bit old, they were last published in 2018 and are being worked on and updated, but these are very, very foundational in terms of promoting multidisciplinary care and treatment for patients with spinal muscular atrophy. Next slide. These 2 volumes actually focus on some different standards of care in fields like diagnosis and genetics, bone health, physical therapy, rehab, orthopedics. And so typically when we have a patient who's diagnosed with spinal muscular atrophy, we will send a copy of these care guidelines to the primary care provider as well, to be able to just understand a little bit in each of these areas over a lifespan, considerations that we have for taking care of patients with SMA. Next slide. We know that just by implementation of these standards of care, that we have improved survival of patients with SMA. So prior to the care guidelines being published, there was an increased risk of death, and that survival curve has actually been shifted with implementation of the care guidelines. Next. However, it's really important to understand that the prolongation of survival doesn't really impact achievement of motor milestones. So care guidelines itself impacts survival, but not really motor milestones. Next slide. We've made changes in that regard in terms of preservation or enhancement of motor function by using disease-modifying therapies. And right now, the disease-modifying therapies fall into a couple of different areas. First of all, the SMN-dependent treatments, including splicing modification, where there's modifying the SMN2 messenger RNA to increase the amount of functional protein that is produced. And those are the agents nusinersen and risdiplam. We also have gene transfer therapy or gene replacement therapy to replace the faulty SMN1 gene using a viral vector-based gene therapy, and that's onasemnogene parvovac. But we also have SMN-independent therapies. None of these are FDA approved at this moment, but clinical trials are ongoing. So we look at the idea of muscle activation. Is it possible to improve the muscle force frequency with an agent such as reldesemtiv, or muscle-targeted agents? Can we actually increase the skeletal muscle mass and therefore the force using a myostatin inhibitor such as apitegromab or teldefgrapab? Next slide. As Dr. Wright showed us, we have newborn screening, and that has been really important in terms of changing these curves of treatment and outcomes. So in graph A, we can see what we expect for motor function over time with the various types of SMA. And in graph B, what we look at is to say, all right, if we can intervene with a disease-modifying therapy, are we able to not normalize, but to alter the loss of motor function in these patients? And certainly the earlier we treat patients, for instance, in infancy, for those patients who are identified on newborn screen, we have better outcomes because we're preventing the loss of more motor neurons. Next slide. What are the FDA-approved therapies that we have at the present time for patients with SMA? So the first approved therapy was nusinersen. That was approved in 2016, and that's for all ages of patients with 5q SMA. So they do need to have a genetic diagnosis. Nusinersen is administered via spinal tap, and there is loading dose initially, and then the agent is delivered quarterly for life. As noted, this was an SMN2 splice modifier. There's some safety monitoring because it's an antisense oligonucleotide, and so we do some safety labs prior to treatment. It's a very safe drug, but some patients will have problems with post-LP headaches. Onasemnogene abeparvovec was approved in 2019, initially just for children who are less than 2 years old. In the European Union, however, they have a weight-based indication. This is given via a single IV infusion. This is the SMN1 transgene that is transferred into the cells to continue to produce SMN protein. Safety monitoring is fairly rigorous for onasemnogene with liver function studies, troponin, platelets. And there are some very significant adverse events that have been seen with this treatment, including liver injury, liver failure, thrombocytopenia, thrombotic microangiopathy. Risdiplam is most recent on the scene, initially approved for patients who are over 2 months of age, but in 2022 approved for all ages of patients with 5q SMA. And this is an oral daily agent, also an SMN2 splice modifier. Prior to treatment, we look at hepatic function and pregnancy test in some of the older patients, as there has been an indication of teratogenicity as a possibility. In general, the agent is very well tolerated with some GI distress, rash, and fever, and there have been some questions about male fertility that's being investigated. Next. If we go through each of the agents, again, nusinersen is injected intrathecally. The idea is that SMN protein is increased in motor neuron cells. The highest concentration of this agent is in the lumbar spinal cord. Half-life is fairly long, 4 to 6 months, and there's a very favorable safety profile with tens of thousands of doses having been administered since approval. There have been some more recent trials on nusinersen, and there may be a change in terms of the dosage of nusinersen in the future. Next slide. With nusinersen, we do have to consider having complex spines. So sometimes it's difficult in patients who have a complicated scoliosis, and we need to use interventional radiology colleagues to help us with transforaminal application. Some sites will do cervical injection, cervical cisterns injection. So the complex spine sort of changes things a little bit in terms of how easy it is to administer this. For the little kids, it doesn't seem to be tremendously difficult, but with little kids, they need to lie still. And so besides using our child-find colleagues, we also use anesthesia at times to help. Respiratory status of the patient is important. As I mentioned, there may be a post-LP syndrome in patients, and many of the older patients will complain of sort of a wearing off effect where they don't feel quite as vigorous and quite as strong just prior to their next dose of nusinersen. And then safety labs have to be done prior to giving each dose, which is kind of a pain in the neck for patients. Next slide. Risdiplam was approved, as noted, for all patients with SMA in 2022. Next slide. Risdiplam, when we consider giving this, we have to look at liver status as it's metabolized through the liver. There are the male fertility questions that are being sorted out, as I mentioned. Possible teratogenicity that has been seen in animal studies. There was concern about off-target effects involving particularly the retina with the initial compound that was tested for risdiplam, but this really has not panned out at all to be an area of concern. This drug does need to have certain storage conditions with refrigeration, making it a little bit more difficult for patients who are traveling or trying to be mobile. Although, again, there's some work going forward on trying to produce a tablet form for risdiplam, which may help solve that problem. We all are concerned about risk for clinical follow-up. So if a patient has a prescription, are they going to continue to come into clinic for follow-up care, which is ever so important, as I mentioned? And then how do we monitor for compliance? We really don't have a way to do that. So we just have to trust that patients are taking their meds or parents are giving the meds to the patients on a daily basis, which can be somewhat challenging for patients as well. Next slide. And then we get into gene therapy. So the idea for gene therapy is that there is delivery of a fully functional human SMN gene that targets motor neuron cells. So the transgene is packaged in an adeno-associated viral capsid. This is not a pure adenovirus, it's an AAV. And for onasemnogene, it's an AAV9 capsid that encapsulates the transgene with a promoter. And again, motor neuron cells are targeted. So we're not changing any other cells. We're really looking at just specifically the motor neurons. And the idea is that as the transgene is kept in sort of an episome in the nucleus, that we will have continued production of viable SMN protein. Next slide. 5q-SMA is really the ideal candidate for gene therapy. It's a monogenic disorder. We have the primary treatment target being motor neurons. Natural history tells us when the best time is to give gene therapy for patients. We are restricted by the age and weight restrictions, but we also know, again, with Dr. Wright's information as well, that we have newborn screening, we can identify patients early, and we can decrease the time to treat just by being aware about how important that is. All individuals with SMA produce some survival motor neurons, so the gene therapy product and transgene should not theoretically stimulate an immune response, and that really hasn't been an issue with this particular agent. Next slide. So with onasemnogene, it is higher risk, and we do see side effects. So in week 1, when we give onasemnogene, we can expect the kids to have low-grade fever, vomiting, diarrhea, feel malaise, they're viremic, they don't feel great. During that period of time, we also see platelets drop in general, and that happens between week 1 and 3. Some of those patients who drop platelets will activate some complement, have renal injury, and we do have cases of thrombotic microangiopathy, and we have to be very, very vigilant in looking at that week 1 to 2. I believe the latest report is that there have been 10 to 13 patients with TMA post-treatment with onasemnogene. And then as we wait, in typically weeks 4 to 8, but typically weeks 6 to 8, transaminitis occurs, and we have to be very vigilant about looking for liver injury. So we have had patients and some deaths with liver failure that have occurred. So we don't treat patients lightly with onasemnogene. We're very, very vigilant with monitoring and watching them during the first several months post-treatment. Next slide. So with onasemnogene, the other consideration we have is antibody status. If a patient has AAV9 antibodies, we can't treat them at that time. We will typically measure antibody status, do some kind of bridging treatment if a family is convinced that they would like to have gene transfer therapy, and then we recheck antibody status to see if perhaps it was maternal, and whether or not the antibodies will resolve. We do have to check liver health for the reasons that I mentioned prior to treatment. The patients are always treated with steroids at day -1, and then through the period of time where their transaminitis resolves. For some patients, that may be 60 to 90 days. There are also patients that we've needed to treat for a year or more, depending on how things go. The patients and families need to understand, so the families for the babies need to understand that there will be frequent laboratory assessments and follow-up appointments, and that's part of the package when we treat patients with gene transfer therapy. The acute toxicities I mentioned. There is also a question of durability with the agent. And we think at this point that the agent is actually durable. The patients who were initially treated in the phase 1 trials are now, I believe, 11 or 12 years out, and there seems to be durability at that point. So for general principles of treatment, I think it's really important to consider the genetic background and the copy numbers for patients. If we have a patient with 2 copy numbers of SMN2, that's an emergency in our mind. If a patient has 4 copy numbers, maybe we have a little bit more time to sit and contemplate treatment, although we would certainly advocate treating those patients as well. We would want to make certain that both primary care providers as well as the multidisciplinary clinic follow the clinical care guidelines and are aware of those. The treatments available depend on the age of the patient at the time of diagnosis. So adults cannot be treated with gene therapy at this point. Outcomes are based on the copy numbers, SMN2 copy numbers, clinical symptoms at the time of treatment, and sometimes we could look at electrophysiologic studies like the CMAPs that will help us a little bit with prediction. We know that earlier diagnosis leads to earlier treatment and better outcomes. That's probably the real takeaway in terms of thinking about SMA is as soon as it's diagnosed, whether it is an 8-day-old or it's an 18-year-old, we should be treating these patients right away because the motor neuron loss continues on, is progressive, it's a neurodegenerative disorder, and we can't regain motor neurons that have died. Next slide. Everyone asks about combination therapies and combination treatments. There really isn't good clinical trial data available at this moment that is a head-to-head comparison of treatment with onasemnogene and nusinersen or onasemnogene and risdiplam or nusinersen and risdiplam. So there's some real-world data that is being reported. Some of it, hopefully will increase over time and we can get some answers. There certainly are potential for combination with SMN1-directed and SMN-independent therapies, such as the myostatin antagonists, apitegromab or taldefigrapab. Next slide. Dr. Wright.
Yeah, so we want to spend some time talking about emergent SMA phenotypes. Next slide. And the reason that we call these emerging is that for 2 reasons. One, in an area of post-disease modifying treatments, we are actually seeing new issues emerge for our patients, and that may be twofold. One is, of course, that traditionally for those patients with SMA type 1 or 2 copies of SMA, unfortunately, they were either on permanent ventilation or they would pass away by 2 years of life. And now, thankfully, they're living longer and are stronger due to early implementation of therapies. And the other thing is that, now what we are discovering is that we are having, a deficit of certain areas of the disease that maybe were not as paid attention to as highly before because of the pressing need of saving these motor neurons that we're now as a field starting to understand that we really need to pay more attention to, both for the quality of life for our patients, but also for furthering, the disease state forward to a point where some of these are less prevalent. And so we're going to highlight a few of these today. I wanted to touch a little bit on this slide of scoliosis. So all patients in the setting of progressive muscle weakness would develop some degree of scoliosis. And traditionally for our children who were type 1, they may not actually have scoliosis if they're predominantly spending most of their time in the supine position, although they may have some degree. It was really for our patients with type 2, type 3 SMA that they may require spinal instrumentation, which of course is helpful for their overall ventilatory and cardiac health when they have a severe degree of scoliosis, usually past 55 degrees. However, actually for our young children, particularly those with a more severe phenotype with 2 copies of SMN2 treated early, they are now sitting sooner. And what we're starting to see is actually for some of these individuals, very progressive scoliosis, even past 50 degrees before the age of 1. And so this is something that's been really paying attention to in the field of SMA. Is this a new phenotype where there are potentially, less directed motor neurons to the paraspinal muscles that's causing this? Unlikely, of course, a treatment-related effect. Or is this something that in the setting of different biomechanics for these children who would never sit that are now sitting is start causing some progression? And that's something that we really need to be looking at. The next is loss of ambulation or increasing difficulty with age. Of course, now we have an area where we can really augment some of these SMN2 and SMN1 modifying therapies, really with some of the potentially muscle enhancement to help with prolonging ambulation and also, decreasing the fatigability that many of our patients feel. Similar to scoliosis, we are starting to get some more reports of torticollis in infants, particularly in our type 1 patients. And is this something that we maybe just under-recognized before the disease-modifying treatments were available? And some of the ones that we'll spend more time on today are neurocognitive issues, bulbar function, language development, and fertility. And so just in regard to bulbar function and language development, we really haven't had a great way to monitor bulbar function in our patients. It was more prevalent, of course, in our type 1 patients who historically would need a G-tube. But now we have a really big role to play in understanding how our disease-modifying therapies may implement and improve bulbar function, and potentially how are the ways that we actually measure this? Because this is something that, when we are focusing really on motor function and the motor neurons, we weren't necessarily paying as close attention to, but this will really be directing the field of SMA for the next 10 years forward, is all of these particular issues that our patients may face. Next slide. So one really emerging concept is neurodevelopmental concerns. And again, I think that this is something that maybe clinicians had recognized in passing, but went under the radar, particularly for some of our more severely affected patients. And so over the past few years, there have been numerous emerging reports and even newer reports since this slide set was created that discuss a higher prevalence of patients with spinal muscular atrophy who have concurrent neurodevelopmental disabilities, impairment in cognition, and potentially autism. And it's interesting to note that, although we think of SMN as being mostly in the motor neurons, it's actually ubiquitously expressed throughout the body, and then it's also expressed within the brain. And there's been some lovely studies that have demonstrated that the SMN protein is actually important for synaptogenesis. So for the creation of those connections from our neurons within the central nervous system and in the developing pyramidal neurons. And so it's possible that there is some overlap, as we know that, many genes in autism spectrum disorder are linked to disorders of synaptogenesis and axonal transport. It may be that a lack of this spinal muscular motor neuron, in the CNS may have some implications, particularly those with more severe phenotype and less copies of SMN2. Next slide. And so there's been a few different, widely published articles. There is a European working group that is looking at neurodevelopment in SMA. And I think it was a surprise to many clinicians in SMA when they did an international survey that these clinicians reported about 43% of all children had some neurodevelopmental comorbidities ranging from autism to learning difficulties to difficulties with cognition. And that was a total of 272 patients. I will note, though, that only 84 of those had a formal assessment, and this highlights two things. One is that we may be, catching more things as clinicians that need to be further investigated, and two, we really need to start validating scales in children with spinal muscular atrophy to start understanding these cognition difficulties sooner. Next slide. And also to highlight the question, does treatment actually impact cognitive function? And we can't say for certain at this point. There's actually only been two groups that have looked at treatment in relation to cognitive function. And of course, we really don't have the natural history controls of this prior to, the implementation of disease-modifying therapy. And so one group, Steffens, looked at the Wechsler scale of intelligence as well as the Baileys in children with either 2 or 3 copies of spinal muscular atrophy and who were treated within the first year of life. And they really didn't seem to find any association to the overall SMN2 copy number or the interval between the symptom onset and start of treatment with regards to cognitive dysfunction. However, they were able to find that those patients who were more severely affected, patients requiring assisted ventilation or needing feeding support, seem to have more cognitive impairment, which I think this highlights two things. One, again, the potential role of the lack of SMN in the central nervous system with regards to cognition and synaptogenesis. But two, the fact that most of our current scales for understanding intelligence do have a gross motor component. It may be very difficult for patients who are using assistive communication devices, minimally verbal, or have, requiring assisted ventilation. So we need to kind of figure out how we're going to navigate this going forward. Next slide. And then there's one other group that actually looked at a different scale called the Griffiths. So the Griffiths is actually a multiple different domains that looks at 5 subscales, essentially foundations of learning, language and communication, also looks at eye and hand coordination, personal, social, emotional skills, and gross motor function. And they actually looked at this in patients, 12 patients who had 2 copies of SMN2, so the more severe phenotype, following treatment after a nosmogene parvimeric at 6 and 12 months. And they demonstrated that essentially that there were some increases in media development really occurring in all subscales except for the gross motor subscale. And again, this scale is likely not directed towards children with SMA. It's not validated in children with SMA, regardless of pretreatment with an SMN2 modifier like nusinersen. But despite this, 9 patients out of the 12 really did have still low to borderline scales across all subscales, indicating an overall developmental delay, not just that of gross motor. Next slide. And so this is really important as we talk about kind of the new approaches, trials, and studies, that how we can really look at these different areas. And so some of the general research areas that we're looking into is biomarker research, which we'll talk about, the improved delivery of our disease-modifying treatments, the longevity and long-term outcomes of in vivo viral vector gene therapy, which, as Dr. Parsons highlighted, now the children who are initially treated are essentially 11 years out and seem to be doing well, which is reassuring for us to see. Adjunctive therapies that may enhance the muscle function as a combination with their disease-modifying treatments. Dr. Parsons already highlighted the combination or sequential therapy. Well, we're having some real world data. It's very hard for us to kind of study this in a randomized controlled fashion. And again, like I mentioned, the importance of understanding cognitive and neurodevelopment in SMA. And then one of the other topics for research that's looking forward is fertility in SMA and how we can improve fertility for our patients. Next slide. And so biomarkers in SMA. One would think that at this point we have some, very good biomarkers for trending, but it's actually been a very difficult disease to understand and identify biomarkers. So the strongest biomarker we have, of course, is the SMN2 copy number. But as we pointed out earlier, a copy number doesn't necessarily predict overall phenotype and disease progression. And so we know from some basic science research that there's also some polymorphisms of the SMN2 gene or the backup gene, and potentially some modifying genes that kind of act in trans to the SMN2 gene that may be modifying a patient's overall course. So the question is, how can we potentially target some of those for individualized care to improve someone's outcome on disease-modifying treatment? In addition to that, further downstream from the DNA, we know that in the protein and the RNA, there are splicing regulators that affect gene transcription. And so can we actually improve for some of these patients who are getting SMN2 therapy, whether that be with an antisense oligonucleotide such as nusinersen or the small molecule mRNA with risdiplam, can we improve some of that functioning as well? And then coming down actually into the nerve itself. So neurofilament has been studied across many diseases, neurodegenerative diseases, because we know actually as neurons degenerate, there's 2 chains of neurofilament that can be elevated. And that may actually be a sign of ongoing neurodegeneration. And although neurofilament can be very high in the newborn period and may drop drastically with some of our disease-modifying therapies, once a patient gets older, it hasn't actually been a reliable, neurofilament hasn't been a reliable biomarker for us to trend. And so we have to see what's the best way that we can use that. What are some normative values for children and adults, and how this may change over time. And then lastly, coming down from where the nerve talks to the muscle, there are ways that we can also look at the changes in the muscle that may be reflective, of course, of the health of the motor neurons. And so for many years, we have used, as discussed, electrophysiologic studies such as compound motor action potentials, or CMAPs, which is the amplitude essentially of a nerve response and reflective of the number of motor neurons. And so some more specific markers of that have been used in research trials. They are very difficult, though, sometimes to trend. They can vary from person to person who's doing the test. So they do have a role, and particularly in clinical trials and monitoring treatment, but we need to find a way to maybe make these easier and have more values provided for children with SMA. And then indicators of muscle integrity. So there's been a big push now to look at adjunctive modalities such as muscle ultrasound to actually look at the overall bulk of the muscle, response to treatment, presence or absence of fasciculations in the muscle. Additionally, muscle resonance imaging or magnetic resonance imaging, MRIs, have been very helpful for muscle diseases. And can we look at other degrees or markers of muscle damage as potential biomarkers going forward? Next slide. And so now we talk about how can we improve disease modifying treatments? What room is there to grow? And so there have been some trials that I want to highlight in particular that are looking at this question. And so in particular, for onasemagine, there's been the STRONG study, and then there's also been the subsequent study that has been going on called the STEER study, looking at intrathecal administration of onasemagine parvovirix. So as Dr. Parsons highlighted, this is adenoviral vector. And so a lot of the systemic response that we see to this adenoviral vector is because it's delivered systemically. And so the question is, can we deliver it intrathecally where it targets the motor neuron cells where they're needed most and decrease some of those systemic side effects? And so far, the study has been done in young adults, and then they are also looking at this in treatment-naive individuals internationally, ages 2 to 18. And what we have seen is that overall it is fairly safe. The markers of systemic delivery of AAV are still present, but we don't have the numbers yet or the number of patients essentially treated with this particular method in bulk to say if it's actually decreased systemic response in the liver or complement-driven activated thrombocytopenia. So that still needs to be remained, but it does seem to be efficacious compared to natural history controls. Next slide. So similarly, there's been a question of giving higher doses of nusinersen intrathecally to see if that can actually improve a patient's overall function. And so this has been the DEVOTE trial, and actually since making this slide, the company has released new data last week that's demonstrated some of the outcomes from part A, B, and C of this trial. And I just want to highlight part C, where essentially what we are doing is for those patients who've already been on nusinersen at the standard dose, they are now getting a one-time loading dose of 50 milligrams at their 4-month mark, and then continuing actually on a higher dose of 28 milligrams every 4 months. And this part C showed that patients in the US and abroad who switched essentially from the low dose to the high dose had no new safety concerns. It was still the same adverse effects that we typically see with nusinersen. And they seem to have some improvements in their ROLM as well as their Hammersmith scores, which are 2 scores that we look at in trend, upper limb module, and then their Hammersmith scores to see functionally how they're doing. And so it will be hopeful to see if that actually is indicative of overall improvement in quality of life, potentially if there's any decreased fatigability and improved stamina for these patients. Next slide. And so Dr. Parsons nicely highlighted some of the muscle adjunctive therapies. So of course, what we know is when the motor neurons are lost, the muscle essentially will atrophy over time. And that's what, of course, leads to the weakness. And so when we think about the muscle, the type 1 muscle fibers are actually preferentially affected in patients with spinal muscular atrophy. So what if we can actually increase the muscle bulk? And so there is a naturally occurring molecule in our bodies called myostatin, which is a transcriptional factor that when it's downregulated to the nucleus can actually inhibit muscle growth. And so this is a molecule that's actually been used in other disease states that was first tried in Duchenne muscular dystrophy. And essentially what 3 different companies have looked at is can they block myostatin and then improve muscle growth? So the first of those, apitegromab, as highlighted, is a indirect myostatin inhibitor. It prevents essentially the breakdown of the prodromes of myostatin and has been shown in clinical trials to have improvements functionally and even on patients who are already on nusinersen. and be safely tolerated. And this is a once monthly intravenous infusion. The next molecule down here that's actually also looking at latent myostatin and preventing that from being upregulated again, because antibodies can sometimes be recycled, is GYM329. That one is undergoing clinical trials right now. And then again, as already mentioned before, there is a direct myostatin inhibitor, which is essentially called Teldografab, which I always say wrong, but is essentially studied by Biohaven, that is looking essentially at directly inhibiting myostatin that's ongoing in clinical trials. Next slide. And so I think one of the most exciting pieces of research that maybe not get as much credit in the past year is actually understanding male fertility and spinal muscular atrophy. So it has been known for many years that individuals who are unfortunately no longer ambulatory, whether they be post-traumatic spinal cord victims or stroke victims, may have decreased sperm counts overall and fertility. But the question of male fertility was really raised, as Dr. Parsons mentioned, because in some of the preclinical trials for risdiplam, which is the oral small molecule RNA, there was suggestion of decreased sperm counts for those animals. And for many of our families, this was a large concern. And so there is a urologist, Dr. Barchama, who did a really wonderful study who looked essentially at where in the sperm cycle is the sperm actually potentially affected. And actually what he was able to show is that the spinal motor neuron, like we talked about, which is expressed throughout the body or ubiquitously, is actually really important also in the testes and is really important for the maintenance and proliferation of spermatogonia and involved in the mitosis phase, which is the prepubertal phase. And so there is a higher rate of male fertility in adults with spinal muscular atrophy that's been shown. Those patients who have severe phenotypes of SMA with 2 copies of SMN2 also have a higher rate of cryptocortism or undescended testes, which can affect male fertility and increase risk for testicular cancer later on. And then what this trial had shown is that really, when we talk about risdiplam as an oral molecule, it's actually affecting a transcription factor called FOXM1 that is only expressed after puberty and meiosis. And so it has not yet been demonstrated in humans, but essentially in animal trials, what they showed was that when there is risdiplam on board for the animals post-puberty, they can have decrease in their sperm counts as a result of this transcription factor being activated. However, once that is actually stopped, the sperm counts do recover to approximately 50% in animals. And so we have a little bit of information and room to understand this even further. But I think that for many of our families who are very hesitant to start this medication in their young children pre-puberty, because of the risk of actual teratogenicity, not teratogenicity, but impaired fertility later on, may have a better reassurance. And it's important for us to kind of understand this, particularly for our patients with more severe types of SMA, of how we can really understand and address this question earlier before puberty to help preserve fertility for some of our young males. Next slide. And so lastly, we just wanted to leave everyone with some key resources to facilitate SMA care. And so as discussed earlier, there are some wonderful clinical care guidelines. I think this was also shared in the chat that Dr. Parsons highlighted. The most recent guidelines were updated in 2018, and I would imagine we'll probably have some more updated guidelines in the next few years as the clinical trials are ongoing and changing. But these both guidelines talk about essentially the diagnosis and management of spinal muscular atrophy and care for each of the organ systems.